My name is Dr. Jonathan Abenheim. I am welcoming you to be able to watch a surgery from beginning to end. This one's a super interesting one. It's maybe one like you've never seen before, how we go through all different complications and issues that come up and how we use technology to give people teeth the same day. Surgery takes 0 hours all the way to 3 hours. That's how long it takes. Double arch, 3 hours. Watch how we do it. Here we go. All right, so we're gonna do a nice double arch case here. This case is done with Dr. Zelig. He did the upper, I did the lower. She is under sedation right now, and although it looks like she's got a ton of bone, you'll see right quickly that that is definitely not the case. So we make sure that she's nice and anesthetized and protect the back of the throat. This is open airway. Because of her low platelets, we started to use electrosurge to minimize the amount of bleeding that she has. And he goes ahead and does his full incision. And he's reflecting real nice up against the bone so that there's very little bleeding. And you can see obviously all that exostosis around there, but we're going up really quickly and really high. And you'll see in a second why that is. And you can see that obviously she's got a lot of bleeding around that area. We remove the bite block to be able to get access. And Dr. Zelig likes to go full flap all the way around. I like to do just half-half. But we go ahead and we measure where our new incisal edge is going to be. And we mark it. And there we go. We start to take teeth out. Obviously, some of them are pretty crumbled. Molar comes out. And we go ahead, open up the palatal flap to be able to see what we are about to see, which you may not know, but you'll see in a couple seconds. Bone rongeur, clean up all the little excesses. We are having a memorial for the bone removal, but boom, what do you see that shows up there? A big rotated canine. And we needed to remove the bone because of her gummy smile in this case. Usually I would not do this, but because of the way her smile is and how we're changing her bite, we needed to do that. And as he does the reduction, you can see the sinus perforation on the left side. But all of a sudden the canine starts to get exposed. And quite frankly, as it gets exposed, you can see it turns into basically an easy extraction. And that is removed. He checks to make sure that our reduction is correct based on my original wax up. Starts to mark the points of where we're going to do traditional implants. And it may not show in the video, but this mouth is legit tiny. We're fighting for space. Spade drill all the way through. .8, and then I tell him stop drilling because we got to get good stability. He makes sure that his tissue is going to be nice and clean. Cleans out all the little excesses with my beautiful black scissors. Anywho, these are Syn 360s. They go ahead, boom, go in real nicely and real quickly, which is great. And then boom, the next one's going. And the next one goes in again. Again, all great stability, about 1 millimeter subcrestal all around. And we have nice little placement around there. 1 millimeter multi-units which will correct the angle with the powerball screw up to 30 degrees. Torque down to 25 Newton centimeters. And then her sinus was extremely anterior. So now we are going to go for the wisdom tooth. Now the wisdom tooth is now gone. He goes all the way up to expose the zygomatic ridge. All the way up to the masseter insertion. Releases the masseter insertion slightly. Uses a round burr at first to make his first purchase point. Goes through the sinus, creates his slot. Sinus membrane is gone, obviously. Her zygoma was actually pretty interesting, really thin and deep. So this required us to be inside the sinus to be able to reach it and still be great prosthetically. And we're creating irrigation. This is a 1 drill. And we only go to the 1 drill. And that's because of the syn zygoma that we're going to place. And great stability. This 52 degree. We're going to go a little bit deeper. As you know, 52 is about a 4.5 millimeter tall. So you got to place the zygoma a little bit better and deeper, even though, say, you would traditionally place a 40. Because of the way Dr. Zelig places it, he creates a massive angle, so the 52 degrees is his standard. I go a little bit more up and down, so I'm more at a 45 degree multi-unit, so I have a little bit more prosthetic room, but with the 52, you got to make sure you're deep enough. And we go ahead and use the mega torque that into another 30 Newton centimeters. He irrigates, make sure there's no bone chips left. Removes the multi-unit, and off we go to the right side. Open, release the masseter. Nice little trick. So we can expose the thickest part of the zygomatic arch and the most distal. You can see that massive curve in the zygoma. Makes his original purchase point. Round diamond coming up. So he can have some room to reach that area. Exposes the bottom of the zygomatic arch. Creates the slot, boom, boom. You can see the nice rotation. And now he has a spot where to go. The first drill. Tiny mouth, so you can see we're struggling to get the parts in. Drill, lots of irrigation. Check to see, he likes to go all the way through. Measures, he's at about 30, 32 approximately. Cleans the bone chips. Comes out the other side, suction real well. And you can see he goes ahead and places the zygomatic implant. Lots of torque. This is a syn implant. And you'd see, because how distal he is in the zygomatic arch, you can see how angled the zygoma actually is. And we're going to go to 52 again in terms of the multi-unit. And because of that, we got to make sure we go a little bit deeper. At a 45, you probably could have stopped there, but we're at 52, so you have to go a little bit deeper. You can see we start to lose prosthetic room. And here we're at. Nice. He begged to put a pterygoid. I told him absolutely not. In this case, we went ahead and put a 2-pal photogrammetry on top. Before we close the flap. And it's nice because you can just screw them in by hand. And I take my little camera, boom, little green light for about 5 to 10 seconds. That's done. And this is a pro tip here. Try not to use a tissue punch to make this because it bleeds tremendously and you'll have a really hard time doing that. And now we go ahead and we close. So we close first the vertical. And these are the Zelig monstrosity sutures of 2.0 chromic, which I absolutely hate, but he loves and he brings them and he uses them. And we go ahead and he starts to close. Very simple interrupted sutures, nothing fancy, but let's bring everything down and get nice closure. These are the THS 2 millimeters to hold down the tissue, and you can see automatically once the THS goes in, the blood just stops. And that's the beauty of my invention, that it creates a scan body and a position for the tissue where it needs to be. You can see the 2 millimeters a little bit high there, so we got to make sure that the tissue is coming down. Could have went to a 1 around there, but photogrammetry forces us to use all the same cuff heights. But I'm telling him, bring it down, bring it down, bring it down, and he's doing that as best as he could. Close up the area where there was the wisdom tooth. Go ahead, boom, everything's nice and closed. And pop the THS to hold the tissue down. Sneak it through, and now you have a beautiful cuff of attached tissue that will stay there. Again, another 2 millimeter THS. And you can see how beautiful the suture just tucks right under the undercut of the THS there. I think Dr. Zelig is now thinking about lunch. Well, this is past lunch, probably thinking about dinner. You can see how fast he's suturing. He's like, I'm out of here. Closing it up. 2 millimeter THS. Suture closed. Gotta make sure the tissue brings its way down, which is one of the challenges with the zygomatic placement. But at this point, I think Dr. Zelig is making a bunch of little jokes. Well, nobody's laughing, but all good. He's closing up. I think he ordered Instacart dinner right now, but he's all set. Takes off his gloves. And we go ahead and we start to do the lower. Put the bite block in. The video is not that great for the lower, but boom, I start taking out all the teeth. And I'm not sure if we'll see it in this video or not, but more importantly, you can see how we're removing the teeth. I make a very, very small flap when I take teeth out. I hate, or just in implants in general, I make enough just so I can see. So we go ahead and identify the mental nerve, go as posterior as I possibly can, and I angle a good 30 degrees. Densa burrs, because you may not be able to see because my flap is not huge, but wow, this bone was super thin, super thin. Again, another Syn implant. I love these implants, how they go in so quickly. 30-degree multi-unit, correct the angle perfectly. We're out approximately mesial to the first molar. And then we move forward. I start to close because I don't want to deal with the blood pooling back there. And this is sort of the hardest time. As the sedation goes on, patient, it's a little bit harder to keep the patient under control, but I suture, I put the THSs, and we move on. This is 4.0 chromic. All right, keep going, take out the teeth. Canine is out. Root tip is out. And now we open the flap. And we try and look for some bone, very, very thin. And we go ahead and place an implant in that area. Get great stability. That was a Megagen implant. Multi-unit is placed. And we continue to the next one. Angled, angled, angled. Depth burr. Send 360. Clean a little bit of bone. Implant was mobile, took it out. Found a new spot. Placed it again. Much better. And we continue. Still doing valvuoplasty as we move along. Angled placement. Implant is placed. You can see how thin the bone is. I did maybe a 2mm implant, 2mm drill, and then I was able to place the implant right through. And I, just for good measure, I'm like, I need to place another implant, trying to find some bone. The bone there is just so thin. Everything is just exploding as I drill. But I was able to get a nice any ridge implant with good stability. Graft. Multi-unit. THSs are placed on top. Suture, suture, suture. We had a little bit of a bleeder there from the alveoplasty. Add a little bit of cortical cancellous bone around that implant. Suture again. Again, fluorochromic. I don't remove any of the tissue tags. I want as much tissue as possible to be sticking around there because I really believe it protects our implants as much as we can. And again, suture where the bone graft is. Keep everything together, as much tissue as I possibly can keep. And THS goes on. Now Zelig is gone. I'm left here to fend for myself. And we got to restore this. So we go ahead, put the 2-pel on. Make sure the 2-pel is clean from my hands. We go ahead and we pick everything up, photogrammetry. One of the tricks I learned is like, don't move. We go ahead and put the small syllabus device to check our bite and our midline and our design right on top of the THSs. Take it out. You can see this is exactly right after surgery. Everything is really nice. We position our device. There's legit no blood. Secure it. And go ahead and scan the lower soft tissue. Set up the lower device. Scan it. Have the patient bite down in the correct vertical. Remove the THSs. After I went and designed screw retain restoration, Powerball 1.0 always in prototypes. Everything goes in as it's supposed to. See as it goes into the soft tissue as we push really hard on it. And we go 10, 10, wait, 15, then 20, and keep going. Then we go to the lower, remove the THSs. Here's a screw retained, printed with dentifab, so it's really, really fast. This is same day, not next day. We're at about 2.5 hours right now. I had a little resin stuck in my access hole. My screw wasn't going all the way down. And then I got it to go. Patient bites, all set. Small little adjustment from the supports. And she is done, ready to go home with teeth. Can start her medications again starting tomorrow. To get her health back under control. But we are all set. She's super happy. And it's done. And that is how upper and lower surgery goes. Zygomatics, impacted canines, thin bone, tissue, really medical history, very difficult. What do you learn from this case? Be prepared. Be always prepared. Know how to suture, know how to reflect, know how to move tissue, know how to deflect, know how to remove implants, know how to place implants, know how to remove impacted teeth. So much to go. Always make sure you have the right technology. Don't send the patient home without teeth. Do it the same day. It can be done. This whole case was done double arch, 3 hours, from extraction all the way to screwing down the final restoration. I hope you enjoyed it. Have a great day. And more importantly, do the best for your patient.